Hello, everyone. This is Dr. Jaisy Vargas. I am recording my video presentation on pulmonary or respiratory disorders. That includes pathophysiology, prepping my students to do well on those tough exams on pathophysiology, pharmacology, and also on APRN state board exams. This video is covering a lot of those common pulmonary disorders that we see in the clinical setting. Here's my two Bible verses for encouragement of students who are, discouraged, did not do well on the prior exams, or had to retake this course or any particular courses or retake exams. This is something for you to read and meditate on so that you can focus on those important key points and study. Like I said, always, I'm not reading off the slides. These slides, I spent tremendous time in preparing them so that I can bring the most important key points on every aspect of these disorders that you may see on these questions. You have the knowledge. You have to know how to understand the wordings, the language they use in these questions so that you can practice as a safe clinician. Important to know the normal aging physiology. A lot of students miss these. So I have 4 key points that is normal alterations in a geriatric population. Loss of elastic recoil, stiffening of the chest wall, changes in gas exchange, and increases in flow resistance. A lot of their illness are not abnormal. A lot of those breathing issues, don't get excited over those symptoms. Know that these are part of the normal aging physiological changes in the respiratory system. Changes can be gradual. They may be healthy looking, they may be ill. It also can be from nutritional factors, body size, and underlying respiratory diseases. Basic terminology is in this slide. Ventilation, diffusion, perfusion. I have highlighted for you to study. Take time to sit down, write this down, and memorize this. And also use your body or your spouse or the children's body as an example, and then practice, these testing, like how the respiratory movements, like the findings on pneumonia, what is a normal lung findings versus the children or adults with respiratory symptoms. So you practice on each other or family members, so you will kind of know these questions, how to answer them. The upper airways composed of nasopharynx and the oropharynx, cilia, hila, goblet cells. All these comes in the board questions. Cilia always comes when there is allergic responses. Goblet cells comes with the cystic fibrosis related questions. And there is a foreign body, the cilia and the goblet help propel the foreign bodies. It helps move the materials upward so that patients can cough it up. Also, a sinus is another one that contains respiratory bronchioles and alveolar ducts. This is also important. So pay attention to the highlighted areas of these slides. It's continued on this slide. Normal aging, elastic recoil, it is explained here. A lot of students don't understand the meaning of that. It is the tendency of the lungs and the chest wall to return to their resting position after a deep inspiration. Basically, it forces the lung tissue and the chest wall in a position and pull on each other. They create a negative pressure, which is normal in the pleural space. VQ ratio comes when it's related to pulmonary embolism, DVT, when patients have asthma, pneumonia, we do VQ scan to detect those. So this is important. Know the normal findings and also the abnormals. What that means, the ratio over 0.8 indicates ventilation exceeds. That is often seen in conditions presented as asthma and pneumonia. This is also kind of like an NCLEX level, but orthopnea. Orthopnea is brought up in these questions. They ask which of these mechanism relieves the breathing issue when the patient is sitting up forward or patient is on a leaning posture. Small respiration, of course, comes with diabetic coma-related questions. Chain stroke also the same way. Know the mechanism of hypoxemia. The high altitude is brought up on these case scenarios, and hypoxemia, why high altitude have more tendency for hypoxemia, because the oxygen level or the content is lessened in these higher areas. Pulmonary edema and pulmonary fibrosis, what is the pathological mechanism, which is also listed here. Hypoventilation and hyperventilation is also important. There's a detailed description of the metabolic and respiratory acidosis. What are the changes with the CO2 and PaCO2 during hypo and hyperventilation? Very important. Know and get comfortable with this slide. Description on the spirometry. A lot of NPs, even after passing the boards, they don't know how to read instant spirometry or PFTs. So this will help you understand what that means. And here are two questions. Herring-Brewer reflex is also seen on some of the questions, so that is explained here. When there is high altitude, it causes hypoxemia through decreased inspired oxygen level. Mucus, remember goblet cells, it is produced by goblet cells produces the mucus and cilia. This is kind of like a repetition, but the key point here is what happens when the patient is alcoholic. What it paralyzes the cilia. Cilia are hair-like projections in the epithelial lining of the respiratory tract, which actually moves or secretions, propels the mucus or the secretions so the patients can cough it up, right? In smoking and alcohol, there are questions. How does it affects the respiratory system? So make sure you study these two. Always keep an eye on these immunoglobulins. Immunoglobulin, IgA, is outfitted in the respiratory system. When there is a pathological process-related questions when patients with smoking, COPD, know this pathophysiology. IgE, if there is an allergic asthma-related question, IgE plays a role in the pathobiology. There are two types listed here, and here's another one with asthma-related question. A lot of students miss this. It's interleukin 5, interleukin 13, and IgE, eosinophils, mast cell, adrenergic receptors, and leukotrienes. They are produced when there is an asthmatic episode because the genes play an important role in the pathogenetic mechanism that stimulates or triggers the asthma. So study this slide. Two types of lung diseases, restrictive and obstructive. You have the knowledge, you just don't pay attention to pick which is the example of a restrictive lung disease because both of them have similar signs and symptoms. So know the examples I have listed here, the common lung diseases that are restrictive and what is restrictive lung diseases shows on a PFT and what's the pathological mechanism. Study this slide. And here's the obstructive disease, lung disease. Common diseases are asthma and COPD. This is very important for all kinds of exams, not just board exams, but clinically you have to know this. So very important slide, study this. I would sit down and write down and make sure that you are comfortable understanding the difference between these two for clinical practice. And also if a patient asks you, what does that mean, obstructive lung disease? What is COPD means? You can easily explain this to them. Asthma is an obstructive lung disease. It's an alteration in ventilation disorder. Inflammatory mediators produced are histamine, prostaglandins, and leukotrienes. You have to know this slide, okay? Allergic asthma, the type 1 hypersensitivity reaction, it involves macrophages, T helper cells, and B lymphocytes, neutrophils, eosinophils, and basophils. And know the difference between acute and late response. Acute response is where these 3 inflammatory mediators are released. Late occurs 4 to 8 hours after the early response. Know that timing. And also here's the pathological process. It releases the toxic neuropeptides that contributes to the bronchospasm. It increases bronchial hyperresponsiveness. Two phases of asthma. Early asthmatic phase is described on the top level. Phase 1 comes a lot on these because there is increased capillary permeability, which is caused by mucosal irritants. And whenever the patient is exposed to that allergen, there is vasodilation, mucosal edema, increased capillary permeability, and bronchospasm. So these are the physiological mechanism. Hypoxemia comes in the late stage. A lot of students think it is early, so it is not in the early stage. It usually happens after we hyperventilate. It stimulates the respiratory center to produce, to decrease the PaCO2 and increases the pH, which results in respiratory alkalosis. So it falls in tidal volume. The highlighted areas you have to know. This will come on exams. Here's a sample question. Besides dyspnea, which is the most common symptom or characteristic feature of a pulmonary disease, it is associated with dyspnea and cough. A lot of students think this big hemoptysis and clubbing and chest pain. I mean, they all have those, but the beginning symptom, they come to the clinic are dyspnea and cough. Surfactant is another term that comes on the exams a lot. A lot of students don't understand the meaning of this, so study this slide. We learn left and right shift in pulmonary disorders. So left shift is where there is acute alkalosis with an increase in the pH. Keep in mind, it's holding your oxygen. So there is increased affinity here. There's decreased temperatures with low levels of carboxyhemoglobin, methemoglobin, and abnormal levels of hemoglobin. Example, carbon monoxide poisoning. So they come on questions with that example, and keep in mind that there is a decreased PCO2 and increased pH resulting in alkalosis. On the opposite side, we have a right shift in the pulmonary disorder. We are letting go oxygen. The patients result in having acute acidosis and a decrease in pH. Their PCO2 will be high, and everything will be high on that because we're letting go oxygen. It stays in the system. So the levels will be high. COPD, very common question on the exam, on these exams. So understand there are two diseases mainly as components of COPD: chronic bronchitis and emphysema. And another question that I've seen is FEV1 FVC ratio less than 70 confirms the COPD. Another one is students miss is asthma. It's not considered a COPD, but it is reversible. But COPD is not fully reversible. Explaining bronchitis, which is a disease of mucus production. A lot of patients has cough over 3 months, which is a significant finding. The productive cough, especially in the morning over 3 months, differentiate bronchitis with other diseases. So study that part, okay? It is the common pathogen causing this is respiratory virus. And squamous metaplasia is another term they use. Normal ciliated pseudostratified squamous epithelium is replaced by metaplasia, squamous metaplasia. Chronic bronchitis, there is hypersecretion, productive cough, at least over 3 months, usually in the winter months for at least 2 years together. And then here's the pathophysiological mechanism. Remember the goblet cells that blocks the airway epithelium. Study this slide. Hypercapnia is important. It causes hypoventilation. Don't make that mistake with hyperventilation. Hypercapnia and hypoventilation. So which pulmonary disease is characterized by requiring more force to expel the air? It has to be an obstructive disease. It could be COPD or emphysema. So look for the answer choices carefully. Emphysema. Here's a slide that describes the pathological process. The loss of air surface is the key point here. Excuse me. There is loss of elastic recoil. So study the slide. Here's the details on that. Hyperexpansion or barrel chest is often seen on these questions. Pathophysiology is loss of elastic recoil. Study that. Common diseases will be lower. Common cause of this disease is respiratory infections, aspiration of oropharyngeal secretion. This is important. One of the common cause of lower respiratory infection is aspiration. This is very common in patients who smoke and also if they are under 40 years age and they are having emphysema related signs and symptoms, think alpha-1 antitrypsin deficiency. This is also an important point that comes on these exams. How do you diagnose chronic bronchitis? Keep in mind, cough over 3 months, ear for 2 years. This slide gives you a different, kind of like a chart that tells you the explanation of both chronic bronchitis and emphysema. Core pulmonary is important. Postnasal drainage, orthopnea, hepatic congestion, peripheral edema, jugular venous distension. So study this slide. This is a clinical manifestation that is very, very common. Alpha-1 antitrypsin deficiency. It is suggested in non-smokers and people below 40 years age. This is also important. Pneumoconiosis is seen on these board reviews, so I put the slide in here in case if there is a question related to workplace exposure or herbicides, patients, veterans who are in the Gulf War or Agent Orange exposed areas where they are military personnel in ship, Navy, they're exposed to paint, asbestos, and depleted petroleum and all of those chemicals. So they might bring that as a case scenario. So look for these key points: workplace occupational hazards. Lung cancer, very common in these exams. So non-small cell and small cell carcinoma. You have to know the difference between these two and the percentage they are in. So patients who are all smokers don't have lung cancers. So people who have a history of smoking, they have small cell lung cancer, which is very common. Non-small cell lung cancer is the common one in those smokers. Exclusively in people who smoke, they might see some SCLC also. But 80 to 85% are non-small cell lung cancer. That's the key word you have to know here. The number one leading cause of death in USA for both male and female is lung cancer. That's one of the questions recently. A student of mine took a APRN board exam, and that was in there. And of course, she thought it was breast cancer, but it is lung cancer. It's a leading cause of death in US for both male and female. These are the key distracting factors that a student may choose the wrong answer. So pay attention to every single word in these questions. So keep in mind, the strongest correlation with tobacco smoking is on the small cell lung cancers. And chest pain is a late symptoms. Non-productive cough is the common signs and symptoms with non-small cell lung cancer. Kind of confusing, but understand the difference between the pathological process and the signs and symptoms, and the tobacco smoking, differentiate them. This is kind of like a repetition because I want to pay attention to those two factors. So the key points, another key point here is the small cell lung cancer. The common type is neuroendocrine lung tumor. I've seen this in the previous question, so keep an eye on this. And then strongest correlation with the tobacco, worst prognosis of lung cancer is the small cell. Tuberculosis, students have overconfidence on understanding the answers of these, but pay attention to the pathological process and how do you diagnose them. Positive skin PPD is not always confirmatory. The gold standard is sputum culture. Highly contagious. It's an airborne disease diagnosed usually by PPD and also the sputum culture, immunoassays, and radiograph. Patients who had BCG vaccines, the PPD will be positive. For those patients, if they are asymptomatic, we just monitor them. But if they have cough, we will do an yearly chest x-ray to detect any active disease. So this slide is important. Gold standard is sputum microscopic work and culture, and the DST testing. Know this, okay? And diagnosed by PPD in the clinical setting, and these are the other diagnostic workup. Patients will have yearly chest x-rays to detect the disease if they have BCG vaccines. This is kind of like a repetition, but I have highlighted, underlined the 6 weeks to become positive part and the radiograph. The same student who took an exam, board exam this past week had this question, and she did not know that was chest radiograph. So I'm bringing that information to this slide. Patients who have current or previous active disease, they have any characteristic changes, chest radiographs is the one that you would recommend because sputum culture takes 6 weeks to become positive. Another thing that you will see is on the questions are which part of the lung tissue you will see nodules, calcification, cavities, hilar enlargement, or enlarged mediastinal lymph nodes. These are usually seen in the upper lobes, okay, not the lower. Pulmonary embolism, very important because since we are discussing pulmonary disorders, I have added that slide here because we are reviewing hypoxemia, hyperventilation, and also patients who had D-dimers. So D-dimer measures the thrombus degradation by the fibrinolytic system. And if the D-dimer is normal, it makes the presence of a PE highly unlikely. So then you want to do a CT scan of the chest. That is the highly sensitive specific test. In addition to radionucleotide ventilation perfusion scan. All of these depends on the insurance and the availability of the hospitals. Normally in the emergency room, they do a CT chest and a D-dimer. So know this example, ventilation perfusion mismatch. Cystic fibrosis, autosomal recessive disease. Here's the question example that I have posted here. You have to know the pathological mechanism of cystic fibrosis. You will see that on a lot of questions. Pneumonia. Know the signs and symptoms. Remember earlier we talked about common pulmonary signs and symptoms is chest pain, dyspnea and cough. In pneumonia, aspiration of oropharyngeal secretion is the most common route of lower respiratory infection. You must study this and you should not miss this, okay? Clinical manifestation is symptoms of upper respiratory infection. Now, a lot of times it's viral, and they have cough, dyspnea, and fever. It can be productive or non-productive if it's viral. Other symptoms is when they really seek ER admission is when they have fever, chills, malaise, and pleuritic chest pain. Then we do a chest x-ray, also physical examination. You have to know these terms: pulmonary consolidation, inspiratory crackles, increased tactile fremitus, egophony, and also whispered pectoral leaky. This is important. Pectoral leaky is often seen on the sports. So study that. Demonstrate the signs and symptoms of systemic diseases or sepsis. Patients, all of these have fever, dyspnea, and cough. They will have hypoxemia. Oxygen saturations are low. That basically we can diagnose it in the clinic by these physical exam findings. ARDS. ARDS comes on these questions rarely, but you have to know these. If you're taking a patho exams, know the pathophysiology of ARDS. Alveolo-capillary membrane is injured with pulmonary inflammation and also has increased capillary permeability, and edema of the pulmonary sac. So all those severe pulmonary edema. This just results in impaired diffusion of oxygen through those alveolo-capillary membrane. And due to this injury, it can be from aspiration, inhaling toxic fumes and gases, for those soldiers in the Gulf War zone area. Excuse me. And then circulating inflammatory mediators are responsible for systemic signs and symptoms. Patients will have sepsis and trauma. These are the 6 phases of ARDS with the common findings. You will have to write it down and study and memorize. These are the same terms we explained in the previous slides, so know those. This is pleural effusion. Patients with pneumonia or COPD or lung cancer, they have these pleural effusions. You may see the sources of accumulation, where they are located. You may see hemothorax on the question and see where is the source of fluid. Hemorrhage is in the pleural space in hemothorax. If it's a hydrothorax, it is in the capillaries or the lungs, chest wall. And then the common disorders are associated with kidney or liver disease, hypertension, anything that decreases the oncotic pressure in the blood vessel causes hydrothorax. You'll also see the term exudate. Know these. What does the exudate mean? It contains leukocytes, plasma proteins, and also it goes into the out of the capillaries. And then we have primary or associated disorders. With that, exudates is any kind of infection in the lungs, lung cancer, mast cells that releases biochemical mediators. Again, increased capillary permeability is the key word. Empyema is rarely seen, but I have seen these questions on empyema examples. This is the mechanisms here. And infections like lung abscess and infected wounds and pneumonia. Hemothorax usually with the trauma, post-op surgical cases, patients who have malignancy, they have damaged blood vessel causing hemothorax. Then we have chylothorax, which is milky fluid containing fat droplets. This is also seen in infection and any trouble with the lymphatic transport, traumatic injury, you'll see those. Here's my exam taking skill tips, a few personal tips, which is my own personal experience with teaching students. Look for those keywords and ask the question. Read the question back to you and then look for the mechanisms, pathological processes, risk factors, and know that you already know the answers, eliminate the wrong answers, and then pick the right one. I hope you enjoy studying this pulmonary disorders video, and I'm sending you all wishes and good luck and sending you warm hugs and wishes. I hope you enjoy this video. Have a pleasant time studying this. Reach out if you have any questions. I'm here to help you. Thank you.